Okay, so we'll start with ischemic heart disease. So can someone tell me what ischemic heart disease and what's the main cause of it?
It's like when there's a clot or a blockage in the arteries that causes, like, let's say, an organ to lack blood supply.
Yes, and which is the or which arteries are these that are involved in ischemic heart disease?
I'm not sure. I'd say
Coronary artery.
coronary.
Yes. So ischemic heart disease, also called as coronary artery disease. So the main cause of ischemic heart disease is atherosclerosis, which is the blockage of these coronary arteries that supply oxygen and nutrients to our heart. So if that is blocked, then your heart cannot function properly because it's not getting that oxygen or those nutrients. So anyone knows how atherosclerosis, like that pathogenesis of atherosclerosis, just like a brief overview?
I think it's to do with the LDLs. I think yesterday I said it. So when it's not cleared fast enough, in between the vascular layers, there's gonna be buildup of these LDLs, and then they're gonna form a plaque, and then that's gonna cause the narrowing of the arterial, the wall or the space for the artery.
Yeah, exactly.
Is it?
Yeah. So let me just share something so I can. Okay, you guys can see my screen.
Yes, Hero.
Okay, so atherosclerosis, what is the main, like, how does this come up? The first thing that happens is an injury to your blood vessel. And when you have this, when your blood vessels are injured and you have like high levels of this LDL, that type of cholesterol, it usually binds to your blood vessels. This LDL, there'll be excess accumulation of this LDL. What happens to this LDL is that it will be oxidized after it's attached to your this blood vessel that has been injured. When this happens, when this LDL is oxidized, it attracts these monocytes, which are it attracts these monocytes, and these monocytes from the blood vessel, from the blood itself, and they will go they will leave the blood and they will enter this between the intima and the media. Yeah, so all this process happens between the tunica media and the tunica intima, which is the first innermost layer and the middle layer. So once these monocytes have entered this space, they will turn into macrophages. Macrophages, we know they phagocytose antigens or just anything that is not supposed to be there. So this oxidized LDL is phagocytosed by the macrophages, and these macrophages keep on the macrophages keep on phagocytosing this LDL and they become foam cells. So all this that we've seen all these are just foam cells, and they accumulate beneath the tunica intima, forming a fatty streak. So over here we can see that this whole thing is a fatty streak. Then the what happens next is that this smooth layer muscles that are in the tunica media, they now migrate to this upper layer now, which is to the tunica intima. And so they basically they form a layer on top of that lipid accumulation or this fatty streak. So over here, then this smooth muscle layers, they keep on dividing and they enlarge, and they form like a plaque on the blood vessel, and it bulges into your blood vessel, so that now blocks your blood vessel. That is how atherosclerosis happens, and with time that plaque keeps on increasing, and it partially blocks or completely blocks the arteries, and in this case your coronary arteries. So another thing that happens when this LDL is oxidized is that it inhibits the release of nitric oxide. Remember, nitric oxide is a vasodilator, but now that there's inhibition of this nitric oxide, there won't be that vasodilation. Yeah, so that is what atherosclerosis is. Any question? Okay. So, ischemic heart disease.
Samiha is asking what's the role of the smooth muscle cells in the diagram, like I think in the previous diagram that you had displayed.
Okay, so there's no like role, it's just that it's something that happens when this atherosclerosis or this foam cells it's part of that pathogenesis that happens during atherosclerosis, is that these smooth muscles migrate from the tunica media to the tunica intima, and they just become part of that fatty streak, or basically when foam cells and this enlarged smooth muscle cells come together on top and keep on accumulating in the tunica intima, then a plaque will be formed. There's no like particular role, it's just that something it happens, unless somebody has an answer to that.
Yeah, I think the answer is in the diagram, such that when the macrophage start phagocytosing the fat, the LDL, the macrophage interprets it like it's a foreign antigen, and the macrophage will secrete growth factors and the cytokines, but essentially it's the growth factors. And the work of the growth factors, they work the same way they'd work in an injury. They will promote the smooth muscle cells to migrate from where they are to the place where the growth factor is being secreted from. So the smooth muscles will also go there and form part of the fatty streak together with the foam cells. Yeah. So essentially it's the macrophages that, through secretion of growth factors, they call the smooth muscle cells to the site upon which phagocytosis is taking place. Yeah, even if you zoom in, you'll see it's been written growth factors. Yeah, somewhere just where smooth muscle cells is written, just up there, you'll see it's written growth factors.
Yeah, thank you guys. So I can continue, or any other question? Okay. So ischemic heart disease is basically obstruction of blood flow because of this atherosclerotic atherosclerotic plaque. So it can kind of be like divided to, like, we talk about chronic stable angina or unstable angina, and then angina. And then when we talk about this NSTEMI and STEMI, that's when we talk about that when we're looking at myocardial infarction. So in this one, we'll look at it as angina pectoris. So what is angina pectoris? It's basically discomfort in the chest that occurs when blood supply is compromised to that myocardium of the heart. And there are three types: there's stable, unstable, and variant. What is the main, which medication is given for angina pectoris? Or what is one of the main treatments? Just not looking at it as stable, unstable, variant, just like a general treatment. What would you as a pharmacist tell your patient if they have some discomfort in their chest because of angina?
Let me give nitroglyceride sublingual.
Yes, that's one of the main. Yeah, that's one of the main medications that you give. And another one is not a medication, but something that you would tell your patient to do. Anyone? Okay. So especially when it's for stable angina, you just tell your patient either to take nitroglycerin or to take rest. It is relieved by rest or by taking nitroglycerin, which is usually given as a sublingual. Unstable, it's not relieved by rest or nitroglycerin, and it usually it requires hospitalization because it's that stage that's in between stable and myocardial infarction. Then the variant angina is you take either nitroglycerin or calcium channel blockers. So it's usually classified into 4 classes. In class 1, these classes are similar to what we saw in the previous in heart failure, where in class 1, walking or climbing the stairs does not give you any symptoms. And then class 2, it's usually through emotion or cold weather is when you get these symptoms. Class 3, just when you're doing some physical activity, you you have all this symptoms of angina, like chest discomfort. And then when you're talking about class 4, you're not able to do any physical activity, or even at rest, you have this anginal symptoms. So risk factors, it's just the same for like all of these heart diseases, where cigarette smoking, your age, mostly in men and postmenopausal women, diabetes, hypertension, alcohol, and all those things. So we talked about the pathophysiology, which is basically atherosclerosis. So what I'm going to go to, clinical presentation is again the same, where you have pain in the chest or heaviness. Usually the patient has this pain that radiates on their neck, jaw, shoulder, back, or arm, this one. And yeah, it's just that the patient feels like nauseous, or they feel like vomiting. Yeah, just those symptoms associated with heart diseases. Diagnosis, mostly you do this 12-lead ECG to see this PQRST. Yeah, this PQRST, how they look like. Either there's that ST, depression, or elevation, but these ones mostly you see them in myocardial infarction. In this one, the mainstay, I would say, is coronary angiography, where you see where this atherosclerotic plaque is. So therapy, when you talk about, okay, since we know that what is the cause of heart disease, what do you think the treatment would be?
I think for the non-pharmacological, you'd encourage aerobic exercise, not heavy exercise, just light exercise, because of that ischemic heart disease, like walking at least 30 minutes a day. Then the diet, they should check on their diet so as to reduce if there is alcohol, too much fatty foods, to reduce on also smoking if it's there. Then now for the pharmacological, will be given the CCBs as vasodilators and beta blockers to reduce the demand of oxygen by the heart.
Yes, exactly. So anybody else?
I also think on management, we can give cardiac aspirin, the 75 milligram, to ensure that you don't get platelet aggregations. And in variant of transmetal angina, which is more of vasospasm, the beta blockers are contraindicated. Thanks.
Yes. Okay, so let me just go to, okay, so the main thing that you would do is this revascularization by percutaneous coronary intervention. That's one of the main procedures that is carried out in such a case, or coronary artery bypass graft. But the main one is PCI. And non-pharmacological, of course, it's those usual ones where you lifestyle modifications with dietary modifications, increased physical activity, but not to that extent, because we know that physical activity would worsen the symptoms of angina. weight loss, of course, and of course, smoking cessation. So what is this PCI? It's basically using this balloon stent, which increases now the blood flow of that coronary artery so that oxygen can get to those myocardium. So I'll go straight to this. Okay. So when you know that somebody, what's the first line would be lipid lowering therapy, or those are now your statins. Why? Because cholesterol is the one that's worsening the symptoms of this ischemic heart disease, because LDL is the one that's causing this atherosclerotic plaque. That's the first one. Plus, you have to do lifestyle modifications, and in case of this angina, you give nitroglycerin either sublingual or like over here, there's a spray. Then aspirin, of course, antiplatelets, and aspirin of the dose is usually 75 to 165 mg per day. And if the patient is not does not tolerate aspirin, then you go in, you give them clopidogrel. So when you do that procedure of PCI, you have to give this dual antiplatelet therapy after that stent placement for at least 12 months to prevent any clot formation. Then we said if this patient now has diabetes, hypertension, or any kidney disease, then you consider giving ACE inhibitors or ARBs, and it has like shown that it reduces mortality or morbidity. Then if this patient now has like a prior myocardial infarction, then you consider giving ACE inhibitor or ARB plus a beta blocker. Then if it's variant angina, then you do not give beta blocker. Those are contraindicated because they worsen the symptoms. Instead, you give either calcium channel blockers or these nitrates like nitroglycerin. Then, like before, Gaia said, beta blockers are usually given because they reduce the oxygen demand. And yeah. So, just a minute. Yeah, so this ACE inhibitor should be considered for all patients unless there's any contraindications. And what they do is just they basically reduce the risk of vascular events that are associated with chronic stable angina or ischemic heart disease. So the ACE inhibitors, like we said before, this captopril and enalapril, and ARBs like valsartan, candesartan, telmisartan. So that's it for ischemic heart disease. Any question, anything to add, any clarification? Yeah, then someone tell me what is the treatment for ischemic heart disease.
Okay. You said the treatment for ischemic heart disease majorly is lifestyle modification through diet, exercise, um, and then other pharmacological modalities are you aim lowering the levels of LDL, since they are the one that are leading to formation of the sclerosis. So you'll give antiplatelets. You can give the patient aspirin, and then you give at low doses of aspirin, that's 60 to 100 and something. And then if the patient cannot tolerate aspirin, you can give them clopidogrel and beta blockers. Also statins are used to lower the LDLs. And then if the patient had hypertension, you can give them beta blockers, which are cardioprotective. And then you can give together with ACE inhibitors. Also, calcium channel blockers are used because they'll block the entry of calcium to the smooth muscles. So they will lead to the heart muscles, I mean. So they will lower the contractility, the cardiac contractility. And yeah, and for variant angina, you said you avoid beta blockers because they'll worsen the vasospasm. Instead, you can give calcium channel blockers and nitrates alone. Yeah.
Yes. And then one more thing is that when you give patients nitroglycerin, which is a vasodilator, you avoid giving other vasodilators such as phosphodiesterase inhibitors like sildenafil. So you avoid giving those when you're giving nitroglycerin. And then, of course, the mainstay would be the percutaneous coronary intervention, PCI, the procedure, which is using a stent or a balloon stent to open up that artery so that there's enough blood flow to that area of the heart. When you do this, procedure, you have to give the patient a dual antiplatelet therapy for at least 12 months to prevent any clot formation. Yeah, I think that's it for ischemic heart disease. Any other question or anything else? Okay, so then we'll move on to myocardial infarction. What is myocardial infarction?
Myocardial infarction it's like an irreversible secondary heart disease through prolonged ischemia.
Yeah, anybody else?
Well, in layman terms, it's a heart attack.
Exactly. So ischemic heart disease leads to myocardial infarction if not treated. So what happens in myocardial infarction? It's basically like because now you're not giving any oxygen to that part of the heart, it leads to necrosis, irreversible necrosis to that part of the heart, or that is not getting that oxygen supply, or it is rupture of the atherosclerotic plaque. When these plaques they rupture, they form like an emboli, which can now travel into other parts of the body. But in case of myocardial infarction, it's just irreversible necrosis of the heart muscle, which, like Guy said, leads to a heart attack. So let me just share something. Okay. So can you guys see my screen? Yeah. Okay. So myocardial infarction can be divided into two, which is the NSTEMI and STEMI. NSTEMI is basically non-ST segment elevation myocardial infarction. So when you do an EC that 12 ECG, when a person has this NSTEMI, then you'll see that the ST segment is not elevated. But when you do this ECG on someone who has STEMI, you'll see that this ST segment is quite elevated. So NSTEMI is the artery is not completely blocked, like you can see over. There's still some blood flow, but it's abnormal. There's still, like, this plaque is still building up. Then and a smaller section of the heart is damaged. So it's just if this part of the heart over here would be damaged because there's not enough oxygen going into that, supplied to that part of the heart. And it is less serious than STEMI. So in STEMI, it's complete block of the coronary artery, and a larger part of the heart is damaged. So then what would be the difference between NSTEMI, which I say that the coronary artery is not completely blocked, compared to ischemic heart disease? Anyone? Difference between NSTEMI and ischemic heart disease? Because we know both of them are there's partial block of the coronary artery, but what's one difference where you can differentiate between them?
The biomarkers that are released during this necrosis of myocardial, you can detect them, like the troponin T is detected
Exactly.
in the bloodstream.
Yeah, exactly. Because like I said, there's irreversible necrosis. Necrosis is damage of the cells. When these cells are damaged, they release these biomarkers or cardiac markers like troponin I and troponin T. And we've seen that there are many other like for other organs, like for the liver, we'll see there's ALP or AST, but when it comes to the heart, it's the troponin or the cardiac markers. So just a minute. Okay, Again, etiology or the causes of myocardial infarction, same as before, because we know that ischemic heart disease is the one that causes myocardial infarction. Pathophysiology, again the same, is it's the pathogenesis of how atherosclerosis is formed. One more thing over here, that there'll be ventricular remodeling, because there'll be an imbalance between myocardial oxygen demand and supply. So yeah, so when there's ventricular remodeling, there'll be less, especially like for the left ventricle, which pumps blood to the rest of the aorta, and then to the rest of the body. It like that pumping action will be reduced, so that also affects other organs. So like complications, you'll have this cardiogenic shock, heart failure, valvular dysfunction, bradycardia, and of course a thromboembolization or venous thromboembolism, because like I said in STEMI, that there's usually like there's that rupture of atherosclerotic plaque, which can now travel, which is an emboli now, can travel to other parts of the body, causing blockage to other veins or arteries around the body. Clinical features is the same as the other. Yeah, so diagnosis, like Fatma said, that the cardiac markers are the ones that will be high, like the troponin I and T. So that confirms the diagnosis of an infarction. And of course, like you test for this coagulation test, the fasting lipid panel, which will show that the LDL level is high, the 12-lead ECG, which is important over here because it will show you if it's NSTEMI or STEMI. With NSTEMI, there is no elevation of the ST segment, while in STEMI, you'll have an elevation of the ST. I don't know if there's a picture of that. Let me check. No, there isn't. Yeah. Okay, so what would be the treatment?
The treatment for STEMI or
For both, or whichever one works.
thrombolytics. Thrombolytics for STEMI and anticoagulants for NSTEMI.
Yes. Anything else to add for that? Or anybody else?
I think it will depend on the setup, for example, the facility, because I think the first mainstay to ensure oxygen supply. That means the first thing will be administer oxygen, then look at the facility which is capable of doing the PCI, and then if not, you give fibrinolysis or something like you also give aspirin or clopidogrel for if it has occurred in less than 90 minutes, then or less than an hour, then the aspirin and the others would be of importance. Then because there's a crescendo of pain in this, there's a pain like in ascending order, I think also morphine to reduce the pain will be essential. Then nitrates, then nitroglycerin. Yes, thanks.
Yes, exactly. So when we're talking about STEMI, the first thing you would be giving oxygen, especially if the oxygen saturation is below 90%. Then if you can do the PCI, you go for that. And then after you've put in the stent, you give that dual antiplatelet therapy that was the same in ischemic heart disease, where it's a dual antiplatelet therapy with aspirin, and then or this clopidogrel, and it's usually given for 12 months. Then you also give anticoagulant therapies like unfractionated heparin or bivalirudin, which is a direct. It's a direct thrombin inhibitor, I think. Yeah, direct. Yeah. Then if you cannot do the procedure, then you give, you start with aspirin and this anticoagulant therapy with clopidogrel. And then again, you do the same thing, giving anticoagulant therapy with unfractionated heparin and this low molecular weight heparins like enoxaparin. But in case where like the patient had come late or whatever the case, you give aspirin indefinitely. You just give aspirin. You can also give the clopidogrel, and then you can also give beta blockers within 24 hours. Yeah, beta blockers are given within 24 hours. Then you can also give the ACE inhibitors, which are also started within 24 hours. And one more thing for this. This one. So this glycoprotein 2B or and 3A receptor inhibitors like this one, you give them when the patients are undergoing PCI and they haven't received any fibrinolytics. So you give this. This is the the choice when fibrinolytics are not given. Yeah, then yeah, and then nitrates like nitroglycerin can also be given. Again, it is contraindicated in patients taking phosphodiesterase 5 inhibitors. Beta blockers should be given within 24 hours and continued. One of the main benefits for these beta blockers is that they decrease oxygen demand, so that's a good thing. Yeah, then you can give this metoprolol, propanolol, atenolol, but they're given as IV. Then, of course, calcium channel blockers, but they only relieve the ischemic symptoms only. Then, yeah, then the fibrinolytic fibrinolytic therapy. It's usually used in STEMI, but it's not indicated for NSTEMI. So this includes this alteplase, reteplase, all this streptokinase. But if the patient has any of these, then fibrinolytic therapy should not be given. So if there is active internal bleeding or intracranial hemorrhage, because we know that fibrinolytic therapy will increase risk of bleeding, so you don't, or if there is uncontrolled hypertension, then in these cases, then you don't give fibrinolytic therapy. Yeah, so that's usually given when PCI is not available. So that's within 30 minutes. And then after that, you start your dual antiplatelet therapy, then go to anticoagulant therapy. For NSTEMI, it's usually, it's almost the same. Again, you give oxygen if oxygen saturation is below 90%. Yeah, it's basically the same, but over here now you consider that PCI, then you give aspirin and clopidogrel for 12 months. All patients that are receiving PCI should be given aspirin and clopidogrel for at least 12 months. So for NSTEMI, the treatment is similar to what we saw in ischemic heart disease. Then when we're talking about secondary prevention, there's just long-term treatment with this aspirin, beta blockers, statins, of course, because you don't want more of that atherosclerotic plaques, ACE inhibitors. Yeah. I think that's for myocardial infarction. Anything else that you guys can add, or any clarification questions?
Are you Hiral?
Yeah.
How are you?
Good, you?
I'm also good. So like in summary, let's say a person has had a heart attack and an ambulance is there, like let's say the perfect example. So in the ambulance, the person will be given morphine for the pain, oxygen for the saturation to ensure adequate saturation, nitroglycerin, and a high dose aspirin, right?
Yes.
Then they reach the hospital and we will do the percutaneous intervention, after which we'll give aspirin and clopidogrel for 12 months. Then they'll continue aspirin for life. And then also a beta blocker, and we'll consider an ACE inhibitor. Let's say in the perfect situation, that's what we do, right?
Yes.
Okay. I just wanted that summary. Yeah.
Yeah. It's for both of them, it's the same treatment, basically. It's just that for management would be the same. It's just that for now, when you're looking for STEMI, there's just more options where you give, like, ACE inhibitors should be started within 24 hours, nitroglycerin. You have another option of apixaban, which is given when the patient has not received any fibrinolytics. enoxaparins and whatnot.
Okay. Me, I think I'm good now. When they ask for a doctor in the plane, I'll say I'm a doctor.
And then the patient who cannot tolerate aspirin, you give them clopidogrel instead of aspirin. Yeah.
Yes.
Both the aspirin and the clopidogrel, you'll start at the high dose, and then the maintenance one, for the one for continuous, will be the one for the low dose one.
Yes. And just remember, fibrinolytics are not indicated for NSTEMI. It's mostly for STEMI. But even for STEMI, you have to see if this patient has any active bleeding, any intracranial, like neoplasm or hemorrhage. You don't give fibrinolytics for that because it will increase the risk of bleeding or like more bleeding, or even when the patient has uncontrolled hypertension. Yeah, any other clarification questions, please ask.
I joined a bit late, Viral, but did we look at the risk factors for ischemic heart disease?
Sorry, risk factors
For ischemic heart disease.
Yes. So risk factors would be just this where is it? It's just like this modifier. Let me just share that. Here, these are the modifiable and non-modifiable. Just a minute. Yeah, so major risk factors for ischemic heart disease would be the modifiable and non-modifiable, which for modifiable, you'll have all these common ones that would lead to any heart disease with alcohol, overconsumption, physical inactivity, obesity, diabetes, of course, dyslipidemia, because we know that LDL is the major cause for ischemic heart disease and myocardial infarction, and the non-modifiable with age, gender, where men and postmenopausal women are at a major risk factor, and any hereditary cause. Yeah.
And then also like in terms of risk factors, women are less risk factor of atherosclerosis than men in ischemia because of estrogen. Estrogen is what do you call is cardiac protective.
Yeah, exactly. That's why if it's postmenopausal, you'd see like these women getting like during postmenopausal is when they'll have all these issues, or they're at a greater risk. So yeah, estrogen again, yeah, it's it's cardioprotective.
So based on that, Hiral, would you advise a woman on menopause to take hormonal replacement therapy?
I actually just thought about that, but I'm not too sure. I guess it would have other risk factors. Does estrogen cause high blood pressure?
Not really.
No? Okay, maybe I'm not too sure about that. But we can search for that right now.
So what's next, Dr. Hiral?
We can take like a 5-minute break, then we can start with arrhythmias.
I was thinking because heart attack and stroke are very close, we cover stroke first before we go to arrhythmias. Because stroke is essentially the same thing we've described, only that the events are now in the brain.
Yes. Okay, fine. That's okay.
Yeah.
Yeah. So we just take a 5-minute break, then I can start with that.
Okay. Thank you.
Okay, so we start with stroke. Before I share what is stroke.
I think stroke is essentially what we've described, the presence of those atherosclerotic plaques, but in this case, they are on the carotid arteries, the blood supply to the brain. So there's that ischemia to a part of the brain. Yeah. And then the story is the same now after there.
Yeah. So stroke is divided into ischemic stroke and hemorrhagic stroke. So okay. So now we talked about atherosclerotic plaques, and in the previous one we said that it was in the coronary arteries where it blocked block blood flow to the heart myocardium. In stroke, it happens in the brain, or like Guy said, in the carotid artery. So ischemic stroke, there is artery blockage because of that plate buildup. So it restricts the blood flow to a certain part of the heart. And that a certain part of the heart. But when we're talking about hemorrhagic stroke, it's now rupture of a blood vessel, so there's basically bleeding in the brain. So you have different types of hemorrhagic stroke with the intracerebral and the subarachnoid where that's between the meninges. So subarachnoid is usually caused because of like trauma to the brain or rupture of cerebral aneurysm. Aneurysm is basically like a bulged area on a blood vessel that now bursts. That's an aneurysm. And then you have intracerebral, which is this one, which is usually because of hypertension, which now leads to busting of arteries or those arteries bleeding into the brain. And then you also have subdural, which is not shown over here, which is caused by head trauma. So like I said here, so there are different classifications of stroke. Like I said, for hemorrhage, it's intracranial and subarachnoid. With ischemic stroke, like atherosclerotic cerebrovascular disease is one of the main ones. Penetrating artery or an emboli that now blocks an artery in the brain. Cryptogenic stroke, which is cryptogenic stroke, and others that you can see over here. So like I said, like ischemic, we can see over here that the plaque or the emboli blocks the blood vessel, and it stops the blood supply to an area of the brain. Then you have hemorrhagic stroke. So like you see over here, the subarachnoid is between the inner and the middle layers of the meninges, and it's caused by trauma or rupture of the aneurysm. So this whatever we see over here is an aneurysm, which is like a bulging part on an artery. Then you have intracerebral hemorrhage, which is into the brain parenchyma, and it's usually caused by uncontrolled hypertension. Then you have this subdural hematomas, which is now bleeding under the dura dura that covers the brain, and it's a result of head trauma. So hemorrhagic stroke is like, fine, you have bleeding in the brain, how does it affect, like why does it cause stroke? It's because there is all these products because of that the presence of blood in the parenchyma now causes like a mass like neurotoxicity, because you have all these degradation products in the blood which causes which causes death to that part of the brain or some of the brain cells or all that. Then this we said again, ischemic stroke, we know it's atherosclerosis or just an emboli. Then so clinical features would be confusion, trouble seeing, numbness, especially when it's usually like unilateral paresis, which is now weakness to half to one side of the entire, like that part of the body. It's usually like half side, like, or just numbness. Then throwing, vomiting, or inability to speak also. So when you see somebody having this, that's the cause, like they're going through a stroke. So you take them to the hospital. And then with hemorrhagic stroke, it's the main complaint is that patients complain of is a headache, which is like the worst headache of my life, and they usually have this neck pain and this neck rigidity. So for lab tests, again, you look at this this coagulation cascade, like all these proteins, like protein C, S, antithrombin. Then you do a CT scan of the head to see where this plaque is or where the hemorrhage is occurring. MRI, ECG, and the Doppler studies. And then, okay, now treatment. Since we know what causes stroke, what management, what do we do?
I think as a primary prevention of stroke, for the people who are at risk, you wanna control their blood pressure, you wanna control their cholesterol, diabetes, and if smoking, they have to cease smoking and such things. But that is for primary prevention for the guys that are at risk. And also something like aspirin. But once someone already has the stroke, now acutely you want to, for ischemic stroke now specifically, you want to break down the clot. We use that alteplase, usually the first line. But there was a criteria for giving alteplase within the first 4.5 hours. And then also there'll be other, if alteplase is not possible, or after you've given alteplase and the patient has stabilized, now we can start the patient on aspirin to control to prevent further clot formation in the future. So as a secondary prevention to stroke. Of course, and still statins, But for the hemorrhagic stroke, I think for the hemorrhagic stroke, I remember particularly there was a drug called nimodipine that was being given to prevent something called delayed cerebral ischemia. But acutely, I'm not sure what else is given for hemorrhagic stroke. I just know of nimodipine, the CCB.
Yeah, exactly. So for stroke, for ischemic stroke, like you said, there is that criteria that you have to, this one. So if it's within 4.5 hours, then and it meets the criteria for thrombolytic therapy, which is this criteria, this one. If they check this criteria, if they go through this, then you start the alteplase, which is the thrombolytic therapy. If they don't, so okay, just if they do, then you maintain the blood pressure at 180 over 110, and you start the TPA, which is the alteplase. And then now you begin like antiplatelet therapy, after that supportive measures and all that. But if they don't meet that criteria for thrombolytic therapy, you start with the aspirin, with that high dose aspirin. Similarly, when the onset it's past 4.5 hours, then you start with that aspirin. So again, if the onset is within 4.5 hours and it meets the criteria for thrombolytic therapy, you start with that alteplase. Then if they don't meet that criteria for thrombolytic therapy, then you give aspirin high dose within 24 to 48 hours. Then you have all this supportive and preventative care. If it's longer than 4.5 hours, then you start with the aspirin directly. So that is basically the treatment for ischemic stroke. But now when you want like secondary prevention, there are this anticoagulants like aspirin, clopidogrel, or oral anticoagulants. And this oral anticoagulants, they are the choice when you want to prevent stroke and the patient also has arterial fibrillation. So one of the oral anticoagulants is warfarin, and the newer anticoagulants like rivaroxaban and apixaban that are in the market. Then, of course, you need to control the blood pressure, where you give ACE inhibitors, diuretics, and ARBs, because you know that if the patient has high blood pressure, then of course there's like chances of rupture of that atherosclerotic plaque, or just that emboli going to other places, like other parts of the brain. Then statins, of course, because we know that one of the causes for ischemic stroke is atherosclerosis. So you give the statins to reduce the LDL, and low molecular weight heparins. But this is mostly prevention of DVT in hospitalized patients. So that was for ischemic stroke. When you come to hemorrhagic stroke, for like I said, there's rupture of blood vessels. So now we have like an aneurysm in the brain, which is that bulging of the blood vessel. So we need to control blood pressure so that aneurysm does not rupture. So that is one of the main things that you do, is that you control the blood pressure with IV labetalol or nicardipine. Then, like Gaia said, you give, for the subarachnoid hemorrhage, you give this calcium channel blocker called nimodipine, which now delays is recommended for subarachnoid stroke. Yeah, so this table just gives an overview of what you need to give alteplase when the patient meets the criteria and it's within or before 4.5 hours. If not both of them, then you start with the aspirin. Then you give other types, like for secondary prevention, you have clopidogrel, aspirin again, warfarin, or rivoxaben, and then or apixaben, and then for hemorrhagic stroke, you need to control the blood pressure because we don't want any other aneurysms to rupture. So you maintain that blood pressure by giving IV labetalol or nicardipine or nifedipine, and of course the nimodipine, which is the calcium channel blocker, mostly used for subarachnoid hemorrhage. Yeah, so that's it for stroke also. Any questions? Oh yeah, and then when, like, for supportive measures, because you know that the brain is using glucose and sometimes it can hyperglycemia or hypoglycemia can worsen ischemia. So if there is hypoglycemia, you give IV dextrose. If it's hyperglycemia, then you start on the insulin. Sometimes the patient may have fever, so you give them acetaminophen, paracetamol. Yeah. And of course, if there is high blood pressure, you give the labetalol or the nicardipine. Yeah, those are for the supportive measures. Any questions, any clarification, anything to add? Any question, guys? I hope you guys have understood. If there are no questions, then I think we can stop here, and then I can start with arrhythmias, venous thromboembolism, and shock tomorrow. Those are the three other that are remaining. Arrhythmias, it's quite long, so yeah. We can do that tomorrow. Arrhythmias, venous thromboembolism, and shock.
Thank you so much for reading for the thanks.